Greetings and welcome. My name is Michael Le Chevalier. I'm Associate Director at the Lumen Christi Institute. We are excited to be hosting this really important conversation today. Before turning to today's event, I just want to call your attention to a few other upcoming events. We're continuing our series on reason and beauty in the Renaissance next week, Tuesday at this same time. And we're also hosting another important event that is going to be helping us to explore the important anniversary of the 75th anniversary of the bomb a week from today on August 6th at noon, bringing together scholars and bishops for an event entitled Pondering Hiroshima. As you know, August 6th, 75 years ago is when the bomb dropped on Hiroshima, and then a few days later on Nagasaki. An important day, but also one that can push us towards greater reflection about this technology and its continued role within our world. I'd like to thank our co-sponsors, America Media and the Nagy Center for Healthcare Ethics at St. Louis University, who have helped make today's event a success. I'm also especially grateful to our co-organizers, the International Academy for Bioethical Inquiry. You too can also help make our programming a success. Today's event is being recorded, and if you find it to be compelling, you can feel free to share it with others. If you like this event and want to see more programming like this, you can join our newsletter, join our mailing list, and log on to future events, and even share it further. Share our emails, like us on Facebook or on Twitter. If you're watching this today by YouTube, you can like it even now, and other people across the internet will see about it and log in. You can also support our efforts to put on more programming like this by donating today at www.lumenchristi.org/donate. I'd now like to invite Jeff Bishop, who is the Tennant Endowed Chair in Healthcare Ethics, Professor of Philosophy and Theology at St. Louis University, and also the founder and coordinator of the International Association of Bioethical Inquiry, who co-organized this event, to introduce our moderator and our speakers. Thank you, Jeff.
Thanks, Michael. Could I ask our panelists to go ahead and turn your screens on so everybody can see you as I introduce you? Hello, everyone. Thanks for joining us. We're pleased that you could be here with us, and unfortunately, in this sort of setting, on the internet. On behalf of the Albert Nagy Center for Healthcare Ethics at St. Louis University and the International Academy for Bioethical Inquiry, welcome to our webinar on COVID and the color line. First, I want to give a quick note about the International Academy of Bioethical Inquiry. It's a group of several theologians, philosophers, and physicians that all joined together a few years ago because we thought that mainstream bioethics had become too technocratic and too narrowly focused on policy and procedural questions, and had ceased to be committed to the deep engagement in bioethics that we once had with thinkers like Alistair McIntyre and Hans Jonas and many, many others, many theologians like Stanley Hauerwas and Joe Fletcher. So we began meeting on a yearly basis, inviting thinkers who do not normally think of themselves as engaged in bioethics to join our conversation. We are an interdisciplinary group, and we work to get underneath the pat answers that are often articulated by mainstream bioethics. We were supposed to be meeting this week with our partners at the Lumen Christi Institute in Chicago with some international guests, including people from the Pontifical University of Santiago in Chile, also the Pontifical University of Lyon in France, to discuss a topic we were calling integral bioethics. However, because of the current pandemic, we had to cancel our regular meeting and decided to host 3 webinars on integral bioethics, partnering with our friends at Lumen Christi. Given our current situation with COVID and given the racial issues that the United States has repeatedly failed to address, we thought it appropriate that our first webinar should be on COVID and the color line. So we have gathered together 4 panelists for our conversation, and I'll be brief. You can check out all of their accolades from our esteemed panelists later on the Lumen Christi website. Dr. Shawnee Daniel Sykes is professor of theology at Mount Mary University in Milwaukee, Wisconsin. She's a registered nurse by training. Professor Daniel Sykes received her doctorate from Marquette University in religious studies with a specialization in theological ethics with a subspecialization in bioethics. She specializes in Catholic social teaching as it relates to healthcare and is one of the few, and I think maybe even the only, Black Catholic female theologians working in bioethics. Dr. Utibe Essien, Utibe Essien is assistant professor of internal medicine and public health at the University of Pittsburgh. Dr. Essien received his MD degree from the Albert Einstein College of Medicine and completed his residency training in internal medicine at the Massachusetts General Hospital. He has published on the impact of food insecurity, housing, and housing instability on patients with diabetes, and on the influence of race and ethnicity on healthcare disparities. Dr. Essien is a health services researcher who conducts research on racial and ethnic health disparities. Dr. Yolanda Wilson is professor of philosophy at Howard University, and she is just completing a year-long fellowship at the National Humanities Center in North Carolina. Professor Wilson holds a PhD in philosophy from the University of North Carolina at Chapel Hill. Her research interests include bioethics, social and political philosophy, race theory, and feminist philosophy. Professor Vincent Lloyd will be leading our conversation today. Vincent has been a part of our conversations in the International Academy for Bioethical Inquiry in the past, and he is one of our dialogue partners whose interests sit adjacent to bioethics, but we think are nonetheless important to bioethics. Dr. Lloyd holds a PhD and an MA from the University of California at Berkeley. He is Associate Professor of Theology and the Director of the program in Africana Studies at Villanova University. His area of interests are philosophy of religion and religion and politics. Vincent, I'm going to turn it over to you now.
Thanks so much for those generous introductions, Jeff. And I'm delighted and honored to be here with three experts in various aspects of healthcare, ethics, and religion. And we'll be talking about an issue that's very much in the news today, the racial inequities in the healthcare system, as well as the racial disparities in coronavirus related hardships. But we'll be looking forward to putting those issues in broader context, thinking about not only scientific facts, but also their historical, social, political, and economic context. And not only dealing with facts, but also thinking about the values and the sources of those values that inform how we think about these matters. And at this moment, we're seeing a convergence not of healthcare crises on the one hand and racial crises on the other, the long simmering racial inequities in the US and insurgent movements for racial justice, growing into national visibility and international visibility with the protests following from the deaths of George Floyd, Breonna Taylor, and others, and the broader Black Lives Matter movement, focusing attention all the more on the racial inequities in the healthcare system, inequities that are made all the more pressing when we hear about the coronavirus infection rate of Black Americans being often more than twice as high as white Americans, in some communities more than 4 times as high as white Americans. And sometimes we're tempted to approach coronavirus or COVID as a technical problem, just requiring technical solutions. But in the framework of Black Lives Matter, we're called to think about values. And I'm excited about thinking today about how these come together, the technical questions and these questions of values. And I'm asked to remind you that we're very much looking forward to this being an interactive conversation. If you have questions for our 3 panelists, the Q&A feature on the Zoom webinar will be regularly checking, and toward the end of the discussion, we'll be posing those questions to our speakers. But we'll begin, I'd like to begin by asking each of the speakers 1 or 2 questions just to open the conversation. And perhaps I can begin with Dr. Essien. as a medical doctor, I wonder if you could speak to us a bit about how the virus affects the human body and why the virus affects some bodies more than others.
Yeah, definitely. So first of all, thank you again for hosting this really important topic. It's something that many of us who work in the health equity space have been thinking about, talking about, and sharing about over the last 4 months. I think it's really critical to kind of take a broader look at COVID-19 and think about or realize that coronaviruses, this large family of viruses that were responsible for the SARS crisis back in 2009 when I was just starting medical school, and the MERS crisis 4 years after that, are not new. And so this class and family of viruses that typically cause respiratory symptoms such as cough and fever, sore throat, runny noses, have been shown over the last few decades to actually cause crises, certainly, unfortunately, not as severe as the one we're seeing today, but it has been known. The reason, to your point around why it seems to affect certain bodies more than others, really has to do with the immune system. And so the risk factors that we recommend or we advise as some of the key risk factors to consider for causes of severe infection and, unfortunately, at times death from this virus do have to do with the impact on the immune system. So the impact that chronic cardiovascular disease, impact that diabetes, obesity, and chronic pulmonary disease has on the immune system really is the reason that those are a bucket of risk factors. Individuals who have cancer or other immune deficient diseases, as well as the elderly, are the group of patients that we really consider as quote unquote high risk for the COVID-19 virus. And as we're seeing in our society, unfortunately, racial and ethnic minorities, individuals who live or reside in lower income communities and who hold certain jobs are also at an additional risk, not because of any genetic or biological factors, but really because of their exposure and they're under protection from some of these risk factors that we've talked about. And I imagine that we'll go deeper into that during our conversation today.
Thanks. Yeah, it's a great starting point here. I wonder if I might ask Dr. Wilson if you could say a bit more, if you could say a bit about how we might understand the racial disparities that we're seeing in the current pandemic in a broader social and historical context of racial inequities in the US.
Yeah, so first, I just want to say thank you for hosting this event, and thank you for having me to share with my esteemed panelists. So I look forward to our conversation. But to get back to your question, I think that one thing that this current pandemic is revealing is the history of lack of access to health care, the ways that racism and inadequate housing and other forms of economic depression and differences are all kind of coming together and converging on Black people in particular. We're also seeing, similar trends in Latinx communities. We're also seeing similar trends in Native American communities. So I want to make those points also. But the idea that your health or your health status is just about your individual behavior or some sort of luck of the genetic draw is false. And I think that to really understand why things are looking the way that they're looking, we have to understand the role that racism has played historically in terms of where Black people live, what kinds of jobs Black people have. And one other thing I want to highlight is that a lot of the conversation around Black people and wealth gaps and kind of environmental stressors are centered largely in urban spaces where Black people live. But I want to make the point, not just as someone who comes from a rural space, but there are a lot of Black people in rural spaces whose health issues look similar in some ways with regard to kind of jobs and access, but that they're kind of unique issues that come out of living in rural spaces. For example, maybe being 20 miles from a hospital or not having a doctor in your town at all. So I'll stop here. I'm sure some of these other issues will come out.
Great, thanks. And Dr. Danielle Sykes, you have a background both in healthcare and in the study of religion and theology. I wonder if you could say a bit about whether there are ways in which you see religion as part of the problem or part of the solution with respect to these racial disparities that we're beginning to talk about.
Yes, and thank you too for inviting me to be on the panel. I'm very excited to have this conversation. I've been thinking about this conversation for a long time, at least since early March. And so when I think about the issues related to this virus and to the spread of the virus and the role of the church with any type of healthcare access or healthcare disease conversations or experiences, there definitely is a divide. And as I was reflecting on this piece over the last several months, and particularly the Catholic piece, there are so many documents that speak to the role of human life and human dignity. And the human dignity is really because it's rooted in the fact that we are created by God and created in the image and likeness of God. And if that's the case, then we are brothers and sisters to one another. And so we can speak that in a very prominent way. You can find it in scripture, in Genesis, and we can also embody it. But for some reason, we get, I think, conflicted when we talk about there's a separation between church and state, and really forget that individuals really do have the freedom to speak about God and the transcendent in their lives, in worship spaces and any spaces that we have, just given the fact that we have a First Amendment that allows us to do that in this country. And so I want to basically argue that religion plays a prominent role in our lives. This is a religious country that is slipping into, a very non-religious, much more secularized society, but still religion plays a prominent role. And in religion, depending on what denomination or whether or not you're practicing mainline, or maybe you're doing some marginalized types of faith practices, that there is always a higher being or something perhaps outside of that individual. Maybe it's inside an individual, as a secular humanist may argue, that it's bigger than me. And so to have a sense of a higher power in the God in me is also the God in you, or even looking at it in terms of we are being called to live together, not just as individuals, although an individualist ethos has taken over us in the United States and our modern sense of negative rights. We also have to realize that we have constraints on us, and those constraints are built in with different systems and different institutions. And so together, we are really called to be on this journey together to figure out how best we can allow for human dignity and human flourishing. And so no one can do that alone. It really is about a communal commitment and a collective way of being. And I think the virus and the way it has exploded and spread globally really calls us to a greater sense that, human being and human life is really being affronted and threatened at this time. And in our own country, we've lost about 150,000 plus people already in the last 4 to 5 months. And so I think it needs to call us to a deeper sense of reflection, and religion helps us to do that.
Thanks so much. Yeah, and I have a few more questions, and I know we have questions coming in from the audience that probably are relevant to all three of the panelists. So I anticipate a fairly free-flowing discussion here, but I'm prompted by Professor Daniel Sykes's reflections on higher calling and dignity and the resources of Catholic social thought, to wonder how in a healthcare space can those questions of values come to influence medical providers or the conversation that's happening in those healthcare spaces. I think sometimes on the news we hear about comorbidities, which can sound just like a technical term rather than one that might have built in it questions of value already there. So I'm curious for all of your reflections on.
Yeah. Yes. For me, just given the secularization of our society and the marginalization of God speak or God talk in our society, the talk about God as higher power, gets a little kind of weird. And so really, I think it needs to come from the client or the patient to drive that piece, or maybe the person has a ministry partner or someone who's accompanying them in this space to really bring up the question of, well, maybe we need to pray about this, or maybe I need to sit back and reflect on what you're saying to me, because it may be intersecting or intervening or even preventing me from moving forward because there's a conflict. And so religion speak, and given the diversity and pluralism around religious points of departure and things like that, giving our multi-religious perspective in the United States and beyond, we really have to try to understand via questions, and not be afraid to raise those religious or theological questions that may come up within a context of faith and reason and spirituality and emotional spaces that people find themselves. I think if we explore deeper with individuals and their families about what prayer means, or what values are being upheld or even threatened in this situation, the dialogue needs to be expounded upon in any kind of clinical or patient, physician, healthcare professional relationship.
So I can share some of my experiences. I think this pandemic is really moving us as health professionals to expand what our understanding is of our patients' values. Dr. Wilson shared some of the issues around access to healthcare, housing, rurality, employment status, and wealth status, and how all of those factors, these social determinants of health, as many of us are learning in our medical training, influence one's health. And I think religion and spirituality is a big part of that, and something that we need to address in our experiences with our patients, especially in a disease that is resulting in so much morbidity and so much mortality. The fact that individuals are sitting alone in a isolated room without their peer support system, without their family or caregiver support system, is really challenging. And how have we been trained as health professionals to engage with that individual at that really important moment of their lives is something that I think is really being reassessed and reexamined all throughout the medical training curriculum, from the first day of medical school through to residency and fellowship training. So I think that's one part of this conversation. And then you mentioned kind of this idea of a framework for comorbidities. And I think Dr. Wilson, again, your points were in your previous comments really touched on that. I'd love to hear your thoughts there.
Yeah, so one thing that, I kind of think about the broader cultural context also. So I have to fully confess, I am actually not a religious person. But I grew up, in the Deep South in a religious family. And as I say, I'm a Southern Black woman. So there are certain kinds of cultural sensibilities I have around religious practice and spirituality. As Dr. Essien pointed out, one thing that's happening, or that we're seeing with this disease and also with the killings that have the police killings that have really kind of exploded these protests internationally is this idea of dying and what the end of life looks like. So I haven't been able to, for kind of my own psychological reasons, watch the George Floyd video. But one thing that, I understand is that he's calling for his mama at the end of his life, right? And I think about these patients who are in hospitals dying alone. Who are they calling for? Who's comforting them? And then I think about who's left to mourn. And that, so before we logged on, I was watching John Lewis's funeral, and, I was trying to watch every like, okay, I got to log on. Okay, I got to log on. But even the idea of, particularly in African-American communities, this idea of gathering to say goodbye and what that means culturally and psychologically that we can't. So John Lewis had this funeral, and yes, I guess by regular funeral standards, it was a good turnout. But you think about what that homegoing might have looked like had we not been in the middle of a global pandemic, and what that does to those who are left behind, who can't access the rituals of mourning and grieving that form part of the communal nexus. And so I just kind of want to think about the way spirituality weaves through all of it, right? Not just the patient, but those of us who are left behind, and what that means communally, even to risk COVID to come say farewell, what that looks like. So, my own hometown, Albany, Georgia, was a hotspot early on, right around the time that New York was a hotspot. And in fact, the infection rate per capita was much higher than New York's at one point. We were number 3 in the world, and New York was number 7. So, but it's a small town. And interestingly enough, once the contact tracing was done, it was traced to 2 funerals. And so that became another kind of complicated way of thinking about, so these funerals happened in late February, early March. And then 2 weeks later, the town is just exploding with people getting sick and dying and not being able to say farewell, not being able to grieve, not being able to access the kind of rituals of God and of religion and spirituality. And so I want us to keep the communal aspect of that in mind also.
Great. I see we have some questions coming from the audience asking for some clarification around the role of genetics in outcomes around COVID versus other sort of environmental factors or other sort of stressors or other sort of social or disparities. So I wonder if there are thoughts on I guess genetics is related to race, but not entirely the same as race here. If there are thoughts on the role of genetics.
Exactly. I think that's important to make that separation, that genetics are different from this social creation that we refer to as race. My parents are Nigerian from West Africa, and there is no increased rate of COVID-19 experienced in West Africa as we're experiencing here in the United States. So if anything, I think I would love folks to get off of this conversation appreciating that there have not over these last 4 months been any clear genetic or biological association with melanated skin that reduces or increases rather one's risk of COVID-19. And it really, the 3 buckets that I think about these disparities in are the clinical bucket, clinical risk factors, social risk factors, and as Dr. Wilson mentioned, the access to care piece. And unfortunately, Black Americans, Latinx, and Native Americans are more likely to have some of these clinical diseases that are associated with worse infection and with dying from COVID-19, which include, like I mentioned, cardiovascular disease, obesity, and diabetes. but they're also more likely to be experiencing these social risk factors, such as the inability to work from home. That social distance is a privilege narrative that we've heard over the last 4 months. Those who reside in multi-generational small houses where we ask patients to go home and stay away from from someone for 14 days if you have COVID-19. Well, what does that practically look like in individuals who have been redlined into certain environments and certain homes? And lastly, access to care bucket, where 27 million Americans still do not have health insurance today, the majority of whom are from Black and Hispanic backgrounds. And so when we ask patients to ask your doctor about your symptoms, well, what does that group of Americans, what opportunity do they have to be able to do that? And so this idea that there may be potentially a genetic or a biological driver of these disparities is one that I really hope we can move away from and really focus on the critical themes that are driving some of these disparities we're seeing.
Could I just add a quick thing to the access to care piece? So, having insurance matters, right? That determines whether you can go to the doctor. Where you live matters. As I talked about, people in rural communities may not have a doctor in their community at all. But the other part of access to care that's important is even those of us who have insurance, how do we get treated when we go to the doctor? What happens? Is anyone paying attention to our symptoms? It seems as though the youngest COVID patient to die in Florida had symptoms and was sent home, right? So when I think about access to care, I also think about that piece too. What happens when you go to the hospital, if you have insurance, or even if you don't? How do physicians and physicians assistants and nurses and other healthcare personnel treat you when you report symptoms? And I think that that's a part of what happens in the US in healthcare that the healthcare system has to reckon with when it comes to race.
The other thing to add to Dr. Wilson is that whole access to care piece also is, how does one who is either medically uninsured or insured, how do you navigate the healthcare system? Given that there are so many disciplines, so many different types of doctors, and the medical language that is used in the communication to patients. Mm-hmm. And so there is an assumption that you understand technical language, the technical medical language. And to me, that also impacts access to healthcare. And so people can be very frustrated in terms of, well, what did she or he just say to me? And where do I need to go for an x-ray? Or how do I follow up with the respiratory person, or the pulmonologist, if you want to say that, or the nephrologist, if you want to say that? Who are these people? And where do I go? And so there's frustrations around that. And there's also frustrations around access to healthcare, being able to push one when you call this office, or leave this message here, or be transferred to this person. And so all these variances that are there that speak to not only the social determinants and the physical determinants of access to healthcare, but these technical determinants that really get in the way in terms of access to healthcare.
Absolutely.
Yes, when I hear the discussions around access to healthcare, as well as the other factors that Dr. Essien was talking about, it reminds me of the broader discourse around systemic racism that is so much a part of the moral vocabulary of the Black Lives Matter movement, and that so many institutions, ranging from universities to art museums to local community centers, are trying to find ways to address. And I mean, I wonder if you all find that language, on the other hand, the language of systemic racism can also feel to some overwhelming or disorienting or immobilizing. And I wonder for those who, so I wonder what you all think about that sort of framework of systemic racism, and if there are sort of concrete ways using that, with that broader framework, that systemic racism can be countered in the healthcare relationships and institutions.
I think, go ahead.
No, Susan, go ahead, man.
Pardon me? You want me to go? Okay. So when I think about systemic racism, I think of foundations of this country. We have the 1619 Project, and we can call that a foundation where the first African enslaved or indentured servants were brought to the United States. We can see another foundation in 1776 with the Declaration of Independence. We can see another foundation in the Emancipation Proclamation, civil rights, and our modern Black Lives Matter movement. And interwoven in those foundations is a system of whiteness, and that whiteness being superior, or that whiteness really taking front and center in direct opposition to Blackness. And so you have an anti-Blackness piece and a pro-white piece. And the pro-white piece gets interwoven in a cycle in those foundations that over 400 and some years, starting, let's say in 1619, or maybe even going back to Columbus, back in 1492, that there is a system of white privilege that has interwoven itself in all of our institutions and industries, including healthcare, that have allowed certain people to have certain privileges and advantages and benefits to care, to food, to shelter, to the economy, and others not. And so that systematic sense of who's in and who's out gets played out in stereotypes and discrimination and different laws that continue to perpetuate a superior race and an inferior race. And so today, given with the Black Lives Matter movement, if you will, and COVID-19, there is a distillation of these privileges and what is going on that people understand for a long time, back before even Emmett Till, that we've had issues with extreme force with police officers, and we've had issues of discrimination and things like that. And so they have compiled, in terms of a healthcare context, perpetuated our health disparities in a systematic racist way.
Yeah, I think that was a wonderful point, and one that really reminds us to go back to the history. I think so many of the challenges with this moment is the fact that we are narrow. We think we thought back in March or April, like, whoa, there are health disparities in America. I don't understand. Like, what is this? This is brand new information. When if you look back, like was mentioned, Dr. Daniel Sykes mentioned, all the way back to the 1600s, we see these same differences in treatment, whether it was segregated hospitals or it was the Tuskegee experiment that literally resulted in some of the distrust that we're seeing today in the healthcare system. And so the importance of going back to that history is critical. And it allows us to move beyond these incremental solutions to the problems. If we don't see that this is a 400-year history, we think, well, maybe this isn't the moment for us to fix systemic racism. Let's just treat COVID-19. And I think that kind of limited scope of thinking is what leaves us in a situation where in a post-COVID era, we can just go back to the same health disparities that we're seeing today, go back to business as usual in the management of a woman who comes in pregnant and leaves dead with only a child leaving the hospital because of, like Dr. Wilson was mentioning, the biases and racism that they experience within the healthcare system. And so I think I can kind of hear the overwhelmingness nature in your comment, Dr. Lloyd, in terms of why this feels like such a big issue. How can we address it in the health system? But I think we need to appreciate that people have been trying to address this for years, for centuries. People have literally laid out the solutions for how we can do it. And it's just up to us to have the skill and the will to actually put some of those policies into practice.
I wonder, in light of that history and in light of that sort of systematic nature of anti-Black racism and other forms of racism, are there ways in which healthcare researchers or data collectors ought to be doing their job differently, or are there examples of particularly good ways in which research and data collection, especially around COVID, is taking into account these historical and systematic natures of racism?
Well, so I'll just say what I need to say. There have been scholars for decades who've been doing this work, right? And this is part of the systemic racism piece, the institutional racism piece. The people who were caught flat-footed about the idea of health disparities are the same people who have ghettoized and devalued this work over decades. And, you know, the idea of what an academic reputation looks like, what healthcare research looks like, this idea that studying Black people just isn't that important, right? Or that anybody can just wake up in the morning and do it and think about it, and you don't need any special training or have any special awareness or have read anything or have read any particular thinkers or theorized about anything because it's just Black people writing about their diaries or something, is part of what has gotten us where we are now. And if institutions aren't willing to change, right? I mean, we're in this moment now where, you know, every time I check my email, you know, my inbox is full of, you know, we want to talk about race and COVID. Where were you 30 years ago? When not necessarily for COVID-19, but there are a lot of scholars who have been toiling in the vineyard, a lot of researchers who've been toiling in anonymity, a lot of people who've been chased out of the academy, who've been chased out of their research projects because institutionally, Black lives didn't matter. And so, you know, in this moment when maybe some people have a smattering of goodwill that, you know, God knows how long that'll last, I think this is precisely the moment to make those kinds of changes. And we have to think about what institutions value and shifting what institutions value. Does working on Black people get you grants? Does thinking about Black people get you tenure? Does, you know, really caring about our communities in the way that many of us entered the academy thinking that we would be able to, you know, in the face of meeting roadblocks, what kind of decisions do we have to make? And some of that is going to be about large institutions, universities, hospital systems, and even federal agencies like NIH and NSF, who are grantees and who fund a lot of healthcare research. It's about what they value.
We have some questions from the audience on intersectionality and the way that the questions are asking, particularly about race and gender together. And I wonder if any of the panelists have reflections on that, either the specific issue of race and gender together in COVID, or intersectionality as a framework for thinking about health disparities.
I think one thing that intersectionality does is, as a framework, is it enables us to really take the kind of structural aspect of oppression seriously, right? Because it's built into the framework. This idea that the ways that we experience oppression, right, aren't just singular, right? I have race, I have gender, I have a social class, but that experiencing those things isn't just about me checking off boxes of identity, but that the way I move through the world as a Black woman who is, you know, educated and heterosexual is just going to look different, right? In some ways, the oppression I experience is going to look very different than the ways that Black men experience oppression. Sometimes there are going to be similarities and commonalities, but also, what does that look like, not just as I move through the world as an individual, but even functioning in our communities, and what kinds of decisions and policies and practices get made, whose stories are valued when we're thinking about policy and procedure. So I think that intersectionality gives us an important framework through which to think about all of these issues.
I agree with that, Dr. Wilson. I also, when I think about intersectionality, I think of the both and piece of, let's say, race, class, gender discourse, but I also don't want us to lose particular conversations on racism or systemic racism. I don't want us to lose as we supplant those pieces together or connect them together. I don't want us to lose the conversations on classism and sexism and things like that. Because sometimes with the intersectionality, yes, it's important to have this dance that goes on, that we're looking at a both and piece, but also helping us to dissect those pieces and say, so what is race? What is class? What is gender or sexism in the midst of a cycle of prejudice and oppression? Many times we may find it easier to look at the issue of class and maybe sexism, but we struggle with really focusing our energies on understanding systemic racism and what that historical context is. And so it's a both and piece for me.
Well, I think one thing that intersectionality does is it broadens one's conception of what racism looks like, right? And it calls our attention to members of our community whose experiences don't always get the attention that they should, right? So for example, in the context of thinking about police violence against Black people, we see that sometimes the stories of Black cis women aren't as well known. We see the stories of Black trans women aren't as well known. And so I think thinking about what systemic racism looks like is also about broadening the picture of all Black lives mattering, right? If we can't tell a story about race without also thinking about how people experience racism.
One of the questions coming in from Lori Zoloth, a bioethicist in the audience, asks us to reflect on the role of anger in bioethical reflection, which is maybe a sort of second order question here. But I wonder if each of you, I think her question is suggesting that too often bioethical reflection is focused on sort of technical issues or solutions to sort of technical problems, but what role do the emotions or affects play, or should they play in reflecting on bioethics in general, or bioethical dilemmas related to COVID in particular?
When I think of the development of, let's say, the term bioethics, especially as a response to a lot of the issues of medical abuse, let's take Tuskegee, for example, that experiment that went on with the African-American or Negro male in Macon, Alabama, where the cure for syphilis had occurred in the 1940s through penicillin. And we had a perpetual experimentation on Black bodies, Black male bodies, up until the early 1970s. In the 1970s, late 1960s, or 1970s, we had a shift from the term medical ethics to bioethics. And bioethics basically took on a marginalization of theology, which was very, very much integral to the phrase medical ethics. And so we move into a more reasoned, principle-based type of thinking about how to resolve medical ethical issues. And so it becomes a very cerebral, kind of abstract way of having to look at bioethical issues and taking into consideration the particular political or the ethos that's a part of the United States, a very Western type of bioethics that's rooted in a United States point of departure. And so when I think of a reason-based bioethics, yes, the emotions can be there, but I think it's a different discipline, a discipline that would bring in the opportunity to not only bring in like a faith-based, but a psychological, more spiritual, more emotivistic way of being with bioethics. And I think that gets lost. I think the emotions, especially as bioethics is so much a part of the academy, gets lost in the fuller ability to really be angry about, to be happy, to be sad about whatever we're doing, because we're really trying to keep this on an even playing field based in reason.
So I just add, it's funny that you're asking a piece about anger. I just wrote a piece a few months ago in USA Today about the morality of anger. And now I'm working on some stuff on contempt. So, among the philosophers who think about these things, right? I mean, a lot of us think about moral psychology of emotions. And I definitely think that, since you asked specifically about anger, I certainly think that there is space for that, and that that's an emotion that should be explored, particularly in the context of or in response to injustice. That anger shouldn't just be dismissed as irrational, that as a matter of fact, anger is actually quite a rational response. And what one does with that anger, or how one channels it, can shape how we think about what justice looks like.
We have a set of questions also wondering, looking toward a vaccine and thinking about vaccine distribution and the, I guess, soliciting reflections from the panelists on what can be done or should be done or could be done to ensure racial equities or addressing systemic racism in terms of how vaccines are distributed.
So I can jump into that. As a primary care trained physician, vaccination is kind of the name of the game for us. I've been trying to encourage my patients to get their flu vaccine for my 7 years, and only sometimes have been successful. So I, again, just like we've been talking on this call, this is not a new conversation. There have been inequities, both in trust around vaccination, but also in access to, and data to show that Black individuals, Hispanic individuals, and people without insurance access are less likely to get kind of the recommended vaccines. I think the first step to addressing this issue is really engaging with the community. And I think the faith community can play a really important role in this conversation, as well as non-faith-based communities. How are our members of our communities, especially the underserved, and vulnerable ones that are deeply being impacted by this virus, going to receive a new vaccine, a medication that is injected into individuals? People who are already scared to go to the doctor, who are already worried about whether a doctor will take their pain or their symptoms seriously, as has been mentioned. Me and my colleagues talk about this, and we keep saying, we're not going to be first in line, and we've been practicing for forever now, and much less those who have not had the medical knowledge or experience. And so I think that's really, really an important question. First, to engage with our communities, and second, to make sure that minority communities are represented in the trials that are occurring right now. Again, how do we actually do that? It's going to go back to working with these members of the communities to help build that trust. And lastly, even beyond that, it shouldn't be up to Black, Hispanic, Native Americans to run to the trials, to run to be first in line, but it needs to be up to the health systems and the policymakers to make sure that these vaccines are distributed equally. And so unlike the newer cardiovascular medications, unlike the newer cancer medications that continue to somehow miss the individuals who are dying most likely from these diseases, who happen to be Black and brown, we need to make sure that we're getting these vaccines rather to those communities as best as we can.
There's been so much controversy around this coronavirus, and it has reached far and wide via our media resources and things like that, and people talking, to the point where we know, all of us know of a loved one or someone in the neighborhood or someone from the church who's died from the virus, from COVID-19. And so when we're talking about this vaccine, I just feel that there's a lot of mistrust is being built up, and we're losing ground about how to trust a vaccine. We're dragging that history of mistrust forward to today. We're listening to, issues around Black Lives Matter and the shift because of George Floyd's murder and others. But I think it's going to take a while, and we're going to lose people, the minoritized groups particularly. We're going to lose people if we don't have a public policy or policies that are integrated, if we don't have public health education around it, if we don't start on the ground dealing with people and listening to their narratives and listening to their fears, that I think it's going to be a very challenging piece to try to sell the vaccine. Just given the messiness of it that we are encountering now and the confusions around it now and the end of life issues that Dr. Wilson talked about and Dr. Epstein talked about. So that's the next step. We don't even know when this virus is going to come to fruition for us. We don't know how 300 million people in the United States are going to be vaccinated. We have a president that talks about using bleach to clean, and so all of those pieces to cleanse the virus out of the system, or those types of mixed messages. And so the issue of mistrust, I think, is huge as it relates to the fruition of a vaccine to suppress the virus.
I know none of us are policymakers, but if we each had the chance to be whispering in the ear of policymakers today about policies that they ought to advocate for or craft that could help address the disparities we've been talking about, what would the two policies that you would be whispering in the ear, the two main policies that you would be whispering in the ear of the policymakers about be?
I can start. I don't know if I'd be whispering, but I'd be kind of shouting it out into their ears, is that we need to do better at testing. Testing is kind of the original sin, quote unquote, that folks have commented on around this virus. And in order for us to know where to shift our resources, to know how to reopen our schools, how to get our communities back to quote unquote normal or the new normal, we need to know who has this virus. And the continued struggle around testing, the narrative that testing is what's responsible for a spike in diseases, and maybe we should actually back off from testing. All of that is just really wasted time, like has been mentioned, and we need to move forward from it, and we need to just ensure that everyone has the same access to testing as we have to all of the other healthcare system accesses. And next, we really need to help disengage insurance from employment. I think that is a really critical conversation that's not being had, but we experience as high as 40 million people go unemployed back in March. And we're coming to around that time when COBRA is running out and those individuals are starting to lose their health insurance unless they've gained another job. I know we've said that access to healthcare goes far beyond health insurance, of course, but at least that gets you in the door. And so these conversations around how to both ensure those 27 million who don't have insurance and also make sure that those who are becoming unemployed don't lose their insurance are two really important ones that I think we need to have.
I keep thinking of a healthy social contract that's a part of any kind of public policy or policy related. And a healthy social contract is going to include not only negative rights and positive right protections, but also being mindful of social rights and social equality. And so that social equality piece speaks to me and speaks to us as policies that are non-discriminatory, that take out the racist pieces, the practices that have kept certain people in and certain people out. And so with a social contract, we're really talking about growing solidarity, and solidarity in a way that's really going to see each other, to see human beings as those who it must enjoy the gifts of human flourishing and human dignity. And so underlying the sense of positive rights and negative rights and social equality, we must have a really, really healthy social contract that is embedded within the public policy conversation.
So I guess I was thinking really big picture. And so for me, the number one thing I would say would be reparations. And I think that, part of the history of economic disparities, the wealth gap, the health gap, a lot of these things can be traced to what some have called America's original sin, right? It can be traced to slavery. And so I think without a serious reparations policy, and maybe we can talk about what that looks like, but without a serious reparations policy, there are going to be some gaps that just can't be closed. They're just not going to be. And it's not about individual people not trying hard enough, which is often the narrative when it comes to Black people. And then the second thing I would say, and I guess it's kind of related to what Dr. Daniel Sykes says, is although more narrow is what I was thinking, was universal healthcare. And I guess that's kind of connected to Dr. Essien a little bit too. Just universal healthcare that includes kind of preventive medicine visits as just part of, and also strangely in the US, of course, vision care, dental care, and hearing care aren't included even for people who often have insurance. Those are often kind of separate plans that you have to buy. And so for me, the universal healthcare picture would also include those things.
And I think I just comment that that first point around reparations and ensuring economic equity across this country is so critical to that, because unfortunately, if we look across the pond to the UK and see a system that does have universal health care, we are seeing the same disparities where Black, Asian, multi-ethnic communities are dying and being more infected from COVID-19. Again, going all the way back to the top of the hour because of the type of jobs that they have, the types of neighborhoods that they live in, the homes that they reside in, as Dr. Wilson mentioned. So you can't have one without the other. I can only imagine that if we implement universal health care in our country without addressing the economic inequalities, we will just have a universal healthcare disparities system. And so I look forward to folks like Dr. Wilson helping advise along.
And that's where the social contract piece comes in. That's where the healthy social contract comes in. Too.
Yeah.
Well, I know we're running toward the end of our time here, but I wonder if each of us might be able to share one source of hope or inspiration in a very dark time, in a dark conversation that maybe keeps you motivated to be thinking about these issues and engaging with these issues.
So one thing for me, and I don't know about keeping me motivated or general access to this, but I read the op-ed that John Lewis wrote this morning. And I kind of tweeted about it because I thought, I can be so pessimistic and so cynical sometimes. But here, John Lewis penned this op-ed shortly before his death. And, the New York Times published it today since his funeral is today. But here's a man who, as he was transitioning to join the ancestors, right, is thinking about us having hope and moving forward and keeping up good trouble, as he called it. And so that op-ed now is giving me hope and space to think and space to be more positive and more hopeful about the future. And he was intentional about visiting Black Lives Matter Plaza. That was one of the last things that he did in DC. So
I think what gives me hope as I too am reflecting on the use of the media back in the 60s on Bloody Sunday, the television was able to televise what was going on Bloody Sunday. And that got many people throughout the United States and the world engaged in the civil rights movement. Many went then to Selma, to help deal with the March to Montgomery for the voting rights. And so we pushed that 50 years later, and we have a young woman who is using her camera to basically photograph and record the George Floyd situation, and how that sparked or resparked and energized and galvanized the Black Lives Matter movement all over the country and all over the world. And so that gives me hope, in terms of the use of technology in a good way to engage in good trouble, to help us realize that human life is very sacred and Black lives matter. Now, I am saddened, on the other hand, that it takes technology to help bring certain people to a sense of aha moment, that you just can't hear it through the movement, the Black Lives Matter movement, but it takes photographs, it takes video recordings in order for this to happen. And so my hope is there, and I continue to hope against hope, but I also have some sense of, this hopelessness piece that's going to lead to despair. I don't know.
Yeah, I think for me, what gives me the most hope is faith and family. While John Lewis was engaging in good trouble back in the 60s, my parents were growing up as kids in villages in West Africa. I don't think they ever would have imagined that decades later they would be here in the States, or that their son would be engaged in this work or helping to move this work forward. And so I do believe that we are all placed in these moments for such a time as this. And I'm hopeful that conversations like these, that the other 100 or so some odd members on the call, and others around the country who are pushing forward this important message, that we do need to care and consider Black lives, will help make it so that 50 years from now, when my kid is in medical school or working on a Zoom call as well, a lot of these conversations that we're having will be completely different.
Thanks so much to all three of the panelists for a really rich discussion. And I've learned a lot, and I'm looking forward to continuing reflecting on what's been said. I'm sorry we couldn't get to all of the questions, the many questions that participants asked, but I know there will be other conversations like this that continue in the future. And with that, I'll turn it over to Michael from Lumen Christi.
Well, and on behalf of the Institute and all of our viewing audience, I want to thank all of you, and especially you, Vincent, for moderating this conversation and help bringing to the fore these important conversations. And I would commend to each of our audience members that if you are interested in learning more about these conversations, you can actually follow each of our speakers here, whether on their web pages or through social media. So many of our speakers have been engaged in these important conversations. And do also, if you found that there was something to take away from this conversation today, share it. The great thing about having all of these events on Zoom is that they're all recorded and they can continue to have an impact even after the live event. I want to thank our co-sponsors, especially America Media, for helping get word out about this event to broader audiences. And if you want to help support our efforts at Lumen Christi to continue to engage in these conversations, you can donate today at www.lumenchristi.org/donate. Otherwise, once more, thank you to each of our panelists. Thank you to the International Academy for the Integral Bioethics inquiry for organizing this event. Jeff, I'm sorry for butchering the title once more, IABI. And thank you all and have a wonderful day.
Thank you.
Yeah, thank you for inviting and organizing this.
Yeah, thank you.